Dear friends, I'm Dr. Hemraj Chandalia. I'll speak to you today about a very important topic, and that is how to prevent coronary artery disease, coronary heart disease, or what we call ischemic heart disease. Prevention strategies are always valuable while practicing medicine, and to prevent coronary artery disease, we have to understand the causation of coronary artery disease and see what are the factors which are modifiable and which are not modifiable. So, amongst the causes of coronary artery disease are unmodifiable causes which cannot be altered by us, and that is the gender of the patient, and male gender is particularly prone as compared to female gender, except in postmenopausal women, the females also approach a very high incidence of coronary artery disease. The family history is very important because it connotes the genetic background of the patient, and if there have been early heart problems in the family, and that early is not too well defined, but currently maybe at 50 or less than 55 years age, presently will be considered early, and if there are a couple of members having this problem, then we have to be very alert in that given patient and attend to modifiable risk factors very vigorously. And of course, process of aging is immutable and inevitable, and as the age advances, possibility of coronary artery disease increases. Modifiable risk factors are the ones which we need to look at very carefully. There we can help the patient by changing the outcomes. Now, of these modifiable factors, most important is hypertension. Then, of course, dyslipidemia, primary target presently being LDL cholesterol, and diabetes, especially uncontrolled diabetes. More type 2 diabetes more than type 1, because type 1 they start at young age, and coronary artery disease comes much later. Before that, there are microvascular problems. Tobacco abuse in any form, smoking or chewing tobacco, which is still rampant in our population and modifiable, and of course obesity, which is modifiable, but successful treatment in the long run is still very frustrating. So let us take each one of these modifiable risk factors. Hypertension is a very potent cardiovascular risk factor, and important to see what should be the target blood pressure in order to mitigate the effects of hypertension. It should obviously be below 135 systolic and 85 diastolic. However, the desirable blood pressure which you really wish to achieve, if possible without producing side effects of hypotension, then it is 120 by 80. As described in the SPRINT study, there were huge benefits by maintaining in the blood pressure around 120/80. And remember that any BP as low as possible without producing symptoms is our aim, and it should not have postural drop, so that you keep looking at the standing blood pressure in these people. The lowest mean blood pressure is important, and mean blood pressure, is the blood pressure, diastolic blood pressure plus 1/3 of the systolic blood pressure, and the mean blood pressure should not be less than 70 millimeter in order to do cerebral perfusion and renal perfusion. The treatment of blood pressure, of course, there are multiple agents to treat. We won't go into details of that. But initial treatment usually is a angiotensin receptor blocker, then calcium channel blocker, beta blocker, and diuretic. And these four group of drugs form the bulwark of treatment of hypertension. Regarding the pharmacological treatment of hypertension, of course, the groups of drugs that are used are the angiotensin receptor blockers, calcium channel blockers, beta blockers, and diuretic. And a combination of this will control most of the hypertensive patients. Of course, salt restriction is a very important lifestyle measure in controlling hypertension. Some of these hypertensives are exquisitely sensitive to salt intake, but anyway, some lowering of salt intake will help all hypertensive patients. And of course, it is also very important to teach patients to use self-monitoring of blood pressure at home by the newer automated oscillometric blood pressure instrument, which are presently quite accurate. And home readings are very important in taking treatment decisions in treating hypertension, because the readings in the clinics are likely to be usually high or sometimes very different. Another important modifiable factor is dyslipidemia. There, our primary target is LDL cholesterol, which, when estimated and not calculated, is very accurate. Remember that do not accept a lipid profile report where LDL cholesterol is calculated by a formula. The reference range for LDL cholesterol highest is 100 mg per dl. But remember, patients think that when the 100 milligram is there is no need of treatment. But they should be reminded that our therapeutic target is 70 milligram LDL cholesterol. The secondary targets, which we are not yet undertaking to treat, and that is the non-HDL cholesterol, which is really the total cholesterol minus the HDL, and that also can be a secondary target. And of course, the other targets sometimes are triglycerides and lipoprotein little a, which is very difficult to treat pharmacologically, but triglycerides are a very rapidly moving moiety, and it really is possible to lower them considerably, even from the value of 1000 to about 300 or 400, and maybe beyond that you require pharmacotherapy for triglycerides as well. Another modifiable risk factor is diabetes mellitus, and type 2 as well as type 1, type 2 more for the causes stated, and it's a very major cause of coronary artery disease and even other vascular complications, which are the microvascular complications. The A1C targets has been debated many times. In general, we describe less than 7% as the target in most patients. However, it will be different depending upon the duration of diabetes, type of diabetes, possibility of easily controlling without complications, age of the patient, educational background of the patient, and family support available. So, among those criteria, sometimes very easily controllable disease like type 2 in the first couple of years of the disease, you can bring A1C to 6 or even 5.7, as below 5.7 is non-diabetic range. And of course, very complicated, long-standing type 2 diabetics where there is recurrent hypoglycemia, you have to be satisfied with a glycemic goal of 7 to 8%. Now, the blood sugar targets is, you see, 70 to 80% of them should be in the range. That is, when you do the glucose monitoring by a sensor, then you want in range 70 to 80. And remember, the range also is different for different people. So, the range of 70 to 180 given is in general and not really actually a good figure, because many patients you put the clamp down the range to 80 to 140 and many of them 150. In pregnancy, for example, we clamp down to 140 or if possible to even 120. And of course, the comorbidities in diabetes mellitus are very important cause of coronary artery disease, which I described for you, is the LDL cholesterol, hypertension, and of course the last one, which I take up now, are the tobacco abuse and obesity. Another modifiable risk factor is tobacco abuse, either smoking tobacco or chewing tobacco, and the harmful effects of which are very well documented to the public at large. It raises blood pressure, it may also raise sugars, and of course causes carcinogenesis. Tobacco cessation strategies must be honed. Those skills should be honed by the treating doctors. There is a method of immediate cessation called cold turkey method. You try to treat insomnia and constipation which may arise for a week or two, and this may work if the patient is determined. And then there can be slow plan, reduction, with a fixed date. The patient must give you a date where they will bring it to zero. That is very important. And you might sometimes use the nicotine chewing gum in order to wean them, but it is not often used. And of course, their pharmacotherapy, some drugs can help you in patients who find very difficult to get off tobacco, and that is bupropion, you see, given for 2 months, and after 1 month, the withdrawal takes place, and one more month the drug is continued. And of course, Chantix is a newer drug which is not being used extensively but can help in very difficult patients. Another modifiable risk factor is obesity, which is most difficult risk factor to manage on a long-term basis. The prevention can be practiced at various stages of life, that is in childhood, for example, avoiding the very high caloric milk formula or high calorie food. In adulthood, similarly, taking care of the diet which is not very rich in calories. In elderly people who become inactive, again, you see, you prevent it by suitable means, but obviously do not want too much weight loss. And in pregnancy, it should be legitimate amount of weight gain of 12 kilos. And post-pregnancy, you have to safeguard against ingestion of very high caloric foods. And of course, the management target weight loss, remember, is not exactly what is described by height and weight charts, but remember, about 10% of weight loss can restore insulin sensitivity beautifully and can give tremendous benefits to the patient, both regarding triglycerides and regarding their blood pressure and regarding their sugar. So that is an achievable goal, and it should be discussed with the patient instead of showing them a very difficult target which is almost non-achievable. And of course, last of all, is we have to teach the patient how to maintain the weight loss that they have achieved. And of course, bariatric surgery is to be considered sometimes in patients who are grossly obese. They find it very difficult to lose weight. But now, slowly, GLP receptor agonists like semaglutide and of course Mounjaro and Zultofi, the newer ones emerging on the scene, they are very effective in causing anorexia and weight loss. So they might even replace bariatric surgery as we go along. So these are various approaches in preventing coronary artery disease, and in our day-to-day practice, we should always be alert to the possibility of prevention, a long-term prevention in your patients. Thank you very much for your patient hearing.